Good evening, everyone. My name is Alga, and I'm Education Manager at Megagen UK. Firstly, I would like to thank everyone for taking their time out to join us this evening, and to our amazing speaker, Dr. Rana. She's a multi-award winning periodontal specialist with nearly 30 years of clinical experience. She's an international speaker, trainer, podcaster, expanding her impact to thousands over 25 countries worldwide. She's also a founder and creator of Nail It Leadership, MedDen Leadership, and Wellbeing Academy. She is an innovative researcher on the impact of stress, chronic disease, and minimally invasive periodontology. And she is a co-founder of Breathe Dental. Also, to mention, she's also a number one international best-selling author and expert writer on leadership, work-life balance, being happy, and stress management. Guess we all need that anyways. She's also the first periodontist in the UK to incorporate laser into routine periodontal therapy. Now, before we start, can I please request everyone to enter questions in a chat box so Dr. Rana can answer at the end of this session? And please welcome Dr. Rana. Thank you.
Thank you so much, Alga. Thank you. Thank you very, very much. And welcome everybody to this, what is it? It's Tuesday evening in November. I've just come back from spending a week in Florida on a meditation retreat. So I am completely and utterly zen, but that means I need to kind of try and gear up my energy because I'm completely jet lagged as well. So like you said, stress and all the rest of it, I should know how to sort out energy, right? Which I do. So I'm really excited about what I'm going to share with you today. Now, the topic is massive. It is utterly ginormous because we're talking about minimally invasive treatment, which is definitely my passion. You know, the old days of big, huge flaps for surgery, I simply see as barbaric now. There's no need for it. And lasers really do allow us to be minimally invasive. So I am going to, of course, talk about this stuff about cosmetic and perioplastic surgery, but also I just couldn't, as a periodontist, not talk about some of the periodontal results that we can get, and of course some stuff about implants as well, peri-implantitis and soft tissue work around implants. So I can't go into that much depth, but I am going to give you a whistle-stop tour on what's possible and try and give you some teaching points, because some of you may use lasers and therefore give you an idea of how you can get even better with them. And those of you who don't use lasers, then what you might want to consider and how you might get around these particular areas with or without them. All right, so I had better kick off and get cracking. So I think the first thing I really need to highlight more than anything is why treat periodontitis. You know, the days are gone where we should be telling our patients, use a bit of chlorhexidine mouthwash and see the hygienist every 3 months, and there is nothing that can be done, or you've got gum disease because of your oral hygiene and lack of understanding about all of the other risk factors, which we need to look at when we're actually ultimately treating a patient. The other aspect we need to understand with periodontitis is it's now also considered to be an indicator for early death. So this stuff is really serious. You know, it has increased risks of heart disease, diabetes, arthritis, Alzheimer's, some cancers, renal diseases, lung diseases, strokes, all of these things. So we really do need to take this chronic inflammatory disease incredibly seriously. So what else do I need to tell you? Well, this is a little bit of data from from a final consensus report that was published some years ago now by a workshop between the EFP, European Federation of Periodontology, and AAP, American Academy of Perio. So they highlighted untreated or inadequately treated periodontitis leads to loss of tooth supporting tissues. So that's going to bugger up your implants, and of course loss of teeth, which is going to have a huge impact on our patients. We know that, but be that either aesthetically or functionally. Severe periodontitis and caries are responsible for more years lost to disability than any other human disease. That's pretty bad, right? And the perio infections are associated, as I've just told you, with a range of systemic diseases, including leading to premature death. So yeah, we really don't just want to be packing people off to a quick scale and polish, which should be a term you shouldn't really be using nowadays, every 3 months. We definitely want to avoid that. From an economic point of view, Periodontitis costs a lot of money on a global scale. There's an estimated cost in the US of $54 billion in direct treatment and a further 25 billion in indirect costs. So absolutely massive. And periodontitis contributes to significantly the cost of dental disease due to the cost needed to replace tooth loss. So of course, when we're replacing it with implants, and if anybody gets sued for negligence for not diagnosing or treating the periodontitis, the defense unions will always be looking at how much it costs to replace a tooth, so ideally an implant, and that's how they work out their valuations. So there's a huge financial cost as well as cost to quality of life. So hopefully you're all very quickly brought in on why this topic is so incredibly important. So where on earth do lasers come in? So my laser journey started, I think about 14 years ago now, roughly, maybe coming on to my 15th year. And I do use primarily the erbium laser. So there wasn't as much research at the time. There's a hell of a lot more of research now, to which I'm very proud to have contributed to. And so we understand very much the mechanisms of laser technology, and specifically in what I'm talking about, the erbium laser, because every laser will work in a different way, have different what we call laser tissue interactions. It will be doing different wavelengths, do different things to the tissues, and we have a very good understanding of that and a really good pool of research to understand what we're doing, which is allowing us to then help perfect our protocols so that work is much more reproducible. So if I just tell you what this erbium laser, known as the water lathe, is actually doing, well, it's removing biofilm. Why is that important? My goodness, well, biofilm is an incredibly difficult thing to actually remove from teeth, but especially also from our implant surfaces. So the fact we have something that can remove the biofilm from a titanium surface and from around the teeth is really incredible. It is able to remove calculus, although I have to say usually I'll use an ultrasonic for that. But it's very satisfying when suddenly you see a chunk of calculus come out of the furcation when you think you've scaled it and sorted the issue out. It's able to remove the endotoxins. So if we think about that, we're potentially then reducing the bacteremia that we can introduce into a patient's body. And also by removing these endotoxins, we're not sitting there scraping away at root surfaces. So the term root planing, again, is historical. It is not what we do nowadays. It's bactericidal, very strong evidence to show how it's able to kill bacteria, particularly periodontal pathogens, and bacteria that notoriously are very difficult to get rid of, such as AA, where again, historically, the research would have suggested that we actually need to go on to surgery when we have periodontitis that's with a high AA. That's Actinobacillus agrigobacter root surface modification, I'm going to come on to that when I show you some more of these cosmetic cases. But again, when we modify this root surface, the studies show we get an improved attachment of fibroblasts and blood components to that root surface, which means potentially we're going to have a much more stable result. And again, that's what the research, my research and others after me, has shown. We may also be getting a connective tissue attachment as well. So it's going to be more stable than our long junctional epithelium, where pockets typically start to relapse after 6 months, which is why you all come out of dental school thinking perio doesn't work or it doesn't last. Think again. It's able to remove the pocket lining, so we're effectively almost doing curettage. Now, of course, depending how old you are, you may or may not be familiar with that term curettage, but it was something that was booted out many, many years ago, probably 30 years ago, with the idea that, oh, doesn't really benefit to remove or try and scrape away this pocket lining. However, what we do know is that actually with traditional instruments, you can't really remove the pocket lining. You'd be lucky if you removed 30% of it. So with the lasers, we can remove 100% of it and are definitely finding superior results. It's able to remove the granulation tissue. So I'll go, we remove everything that happens to be in an infrabony defect or around an implant. We're then able to expose bone, which is going to allow bone to bleed. So we get release of these bone-derived growth factors to help the bone to regenerate. And also by disrupting the epithelium outside, it delays the epithelium from growing down. So the principles of regeneration used to be putting a membrane in place, which stops the epithelium from growing down and gives us more time for connective tissue to grow up. So the epithelium takes reconstructs itself 5 times faster, so it starts to grow down into the pocket, which is why we get what we call a long junctional epithelium when we just do traditional scaling. So if we delay that epithelium from doing that, then the blood clot that forms is able to act as a membrane. So again, better chance of regeneration and connective tissue attachment and a more stable result. So again, it then helps to stabilize the blood clot as well by warming up that blood and making sure that the blood clot is very thin, which again makes it more stable. And from a patient's point of view, and I'm delighted to say we do have some studies supporting this now, we see a reduction in postoperative sensitivity. So I never tell patients they won't have sensitive teeth, but typically if they do, it usually lasts 1 to 2 weeks as opposed to 3 months. Much less pain after treatment and also much less recession. So we haven't got those huge, big, massive, barbaric black triangles. And as I keep alluding to, longer term stability. So some real indications there from a patient point of view, longer term stability, better results, bone regeneration, less recession, less pain, and less sensitivity. So that is a lot to take in. Don't worry if it doesn't make complete sense, but for those of you who may already use lasers, then that's a recap for you. And for those of you who don't, then hopefully that gives you a wow factor, because that's a hell of a lot. So let me just start off with a perio case here for you. This lady was in her 30s. She's actually one of the first cases I treated. So like I said, probably I think back in 2011 or so. She'd come in saying her gums were really painful, were bleeding like mad. She could barely touch them because of the pain. Now, there was a family history of leukemia in that case. So because it had occurred so suddenly, I did biopsy it as well. Fortunately, it wasn't leukemia, it was just a general inflammatory infiltrate, and she had also quit smoking. So in doing that, her gums had just reacted massively. Let me show you her radiographs. So just to give you a walk around, we tend to look at the upper arch and the lower arch separately. We look at the percentage of bone loss, the shape of bone loss, if there are any furcation lesions, the shape of the teeth, the length of the teeth. So in the upper arch, we've got, let's see, we've got about 30 to 40%, mostly horizontal bone loss. There's a periapical radiolucency on that upper right 6. It needs root treatment. And then on the lowers, we've got some early furcation involvements of the lower 6s, pretty long roots. And then again, say 20 to 40% bone loss around there as well. So remember, she's only in her 30s. But a lot of bone loss, and this is one of my old pockets. I did tell you it was an old case, and we did it on paper. So don't worry too much about the numbers. I just want you to look at the colours. So look at these middle 2 bars, this bar over here and this bar over here, and so you'll see, oops, you'll see that most of the things are coloured in blue, albeit some of them are false pockets because of the swelling. So we've got all of these deep pockets, we've got 100% bleeding, and then everything that's yellow are the medium pockets. So what did I do with her? Local anaesthetic. Never skimp on your local anaesthetic. Don't try to be clever. A lot of people think that they are doing just as good a job without local anaesthetic. Believe me, you're not. You are just adapting to the fact that the patient isn't numb and probably not being as rigorous as you need to be. It also allows you to relax. So Alga introduced me as someone who works with mastering at reducing stress, so that stress no longer exists actually in your mindset. But it is very stressful trying to deal with a patient who is jumping up and down and feeling really uncomfortable. So in the interest of your health, numb the patient up as well. So I would numb them up. I use ultrasonics all the way around. So full mouth, local. So we've got infiltrations, we've got blocks, and then we go in with the ultrasonic, remove all of the calculus. I use a technique called visible debridement. Anyone who comes to my courses will have an understanding of that because they'll get to sit with me chairside. And then I go in with the laser, and I'm going to show you a video. So I'll go in with the laser to do all of those wonderful things that I just told you about. And then I leave my patient to heal for a 2-month period, of course, with brilliant oral hygiene and having assessed any of the other risk factors as well. So I might have decided to give them nutritional supplementation. I might have obviously given them advice with regards to stress, with regards to communication, with regards to emotional intelligence, with regards to possible adjunctive antimicrobials, weight loss, sleep patterns. We look at all of those things. And this is our lovely lady just 2 months later. So it looks like a different mouth, right? And some people have said to me, oh, this is after orthodontics. No, it isn't. It's just those teeth happen to move back into position. So really, really fantastic. And that's how she looked at the start. 6 months on, teeth actually continued to move. So then she might have wanted some ortho. You can see there's that overlap of the anterior teeth, which has gone back to how they used to be. And this patient has remained beautifully stable for 4 years. So that is what is possible in one course of periodontal treatment, treating half the mouth on one visit, other half of the mouth on the next visit, and leaving them to heal up 2 months later. Really incredible. And you saw that there in the pocket chart. So if we move upwards, we've got, you can see there's nothing really coloured in, so she has no pockets, and that has continued. That's 2 months. That's this. The next line up is 6 months. The next line up is a year, and the same going down. So she just used to get the odd 4mm site that would crop up. And I could never really get her bleeding index below 20%, which then does technically put her at higher risk. So I always needed to see her a little bit more frequently for that purpose. But yeah, brilliant stability. So let's look at another case. This guy was referred to me. He'd gone to see many dentists and periodontists, really desperately wanting some bone regeneration around this lower front tooth, the lower left one, which you'll see on the radiograph in a minute, had a one wall defect. Now, those of you who know anything about regeneration will know most of the time we can't, the predictability for regeneration on a one wall defect is extremely poor. And the tooth was a bit mobile. He didn't want an implant. He really wanted to try to save the tooth as much as he possibly could. So he's got some calculus here. You can see his oral hygiene isn't the best. He's definitely got some inflammation, same buccally, a little bit of a frenal pull on the tissues going on here as well. So this is a combined case. I was kind of when I was experimenting where I started using lasers and combining it with the use of PRF as well. So what can I use my laser for? So often when we get patients who are a little bit older, as you know, the quality of the enamel is never quite so good. Now this tooth was loose and I want to try to regenerate bone. So for that reason, I was going to splint it as part of the treatment. Just like when you have a broken bone, unless you immobilize it, the chance of regeneration is poorer. So in order to splint this area with this lower, poorer quality enamel, I have used my erbium laser on this lingual surface once I've cleaned it up. And then I've acid etched. So if I show you what that ultimately looks like, we get this beautiful frosting. I mean, it's amazing. It looks far more remarkable than if we just acid etch by using the erbium laser as well. So it really does help improve bond strength. So this is something you could do for your class 5 composite restorations as well. Or of course, so many of people who do composite bonding nowadays, it doesn't damage the surface. And then you can see here, I've placed a composite fiber splint with perio stick, so we've now stabilized the tooth. So and that they last for years when they're done well. And then I go in, I would have scaled my tooth, and then I go in here on this left-hand picture with my erbium laser. So remember, I'm removing the granulation tissue, which you can see has managed to come out here. So I've just scooped the rest of it out with a curette. So we get all of the granulation tissue out of the defect. We modify the root surface. We're killing bacteria. We're removing endotoxins. We're doing some work outside on the epithelium to stop it from growing back down. And we're encouraging this bone to bleed so that it's releasing growth factors. So it's all done in one stage. And then, so this is the erbium working on the outside. And then after that, we use a different laser, which is a 940 nanometer diode laser for something that we call photobiomodulation, so PBM. So this is working on a cellular level, a biological level. The studies support the fact that actually this is equivalent to giving a patient steroids post-surgery. So it reduces post-operative swelling, pain, can help an area bleed. So it's fantastic for, say, socket preservation and dry sockets, and can also help with lymphatic drainage. So brilliant to reduce swelling. but also depending on the settings we use, it also helps with bone regeneration because the release of certain growth factors from cells. Anyway, it's a very big topic. I talked to you about it on my courses. But anyway, this is what we're doing. For all intents and purposes, it looks like you're shining a red light on the area. And then I did tell you this was a combined case. So I started using some PRF, which we placed into the area, and then the final liquid in that area as well. So that's what he looked like when I finished with him, left him to go off and start brushing it as normal from the next day, pain relief if needed. A couple of weeks later, there he was. I took those little sutures out. That was when I was suturing PRF. I don't do that now. I just use a pack. And let me just whiz through a little bit of this video with you to give you an idea of what that laser movement looks like. So I did tell you, I noticed when I started pulling the lip that there was actually a little bit of a pull here on this margin. So I simultaneously did a little bit of a frenectomy with this laser tip to release that tension. So again, those little frenectomies are something that is wonderful to do, say, for example, when you're working on implants or pre-ear crown lengthening case, because you do not want that margin pulling in any way. We know that periodontitis treatment is much less successful or stable if the margin is mobile. So there I am with my laser. It's called a water laser. There is water that does come out of it. It's just in this case, the suction's taking it away for the video. So we'll often see this water bubbling away. And then we're working, this is called a radial firing tip. So it's working on the pocket lining on one side and it's working on the tooth surface on the other side, which is why we get all of those fantastic biological effects. Let's just skip a little bit. So like I said, I've loosened up all of my granulation tissue now without raising a flap. So I just literally, it's like scooping out a bowl. So I'm not using it, doing anything hard here. I just able to scoop out the bowl really, and get rid of the granulation tissue and encourage that bone to bleed. And then we, in this case, we put the PRF in and a little bit of the liquid when we finished it off. So these were his results. So I showed you the picture of the splint, which looked lovely. And then you can see 2 months later, and then actually this 5-month follow-up, only probing 2 millimeters in the area. So this picture here is after. This is still do with a little bit of cleaning, but most importantly, take a look at the radiograph. So I did tell you it was a one wall defect, right? So we have got some beautiful bone fill in a one wall defect, which is just fantastic. And obviously that patient continued to go on to retain and keep that tooth for many, many years to come. So this procedure is most definitely reproducible. Just a few other cases to show you before I go on to some implant work. So this patient, he was actually in his 80s. He had a very deep infrabony defect here on the distal of the lower right 7. The pocket was 15 millimeters. And then also a 10 millimeter defect with this vertical defect here on the lower left 7. So I've treated him very similarly to what you saw in that video, but no PRF. The PRF was just me experimenting to see if I could get a better result, which actually, once I used 2 lasers, there was no need to add PRF to the regime. It didn't get any better results. But anyway, here is my chappie at the age of 80. So you can see this 15 millimeter pocket. Look at that bone fill. Now I have not put bone in here. I have not used Endogain. I have not used PRF. I have used nothing other than taking advantage of the patient's biology, because that's the question I always get asked. What have you put in there? Absolutely nothing. This is the patient's bone that has regenerated and the pocket has gone down from 15 millimeters to no pocket at all. So likewise on that left side, that vertical defect there, and we've gone down to 2 millimeter probing depths, which remained stable for years and years, which is really, really satisfying. Here's another one. This lady was about to have surgery carried out at one of the teaching hospitals. So she decided to find me because she didn't want surgery. And here we have, again, an infrabony defect, an 8 millimeter pocket, bleeding on probing. And then after that minimally invasive laser treatment, you could call it, of course, minimally invasive surgery because we are touching the bone. You can see we've gone down to 3 millimeters and a nice bit of bone fill there as well. Also notice minimal recession, which, like I said, remember with the erbium laser, we get much less recession than we would if we were going to do traditional surgery. And one of the beautiful things, obviously I have been doing this for so many years now, is I'm able to report, just like any other regenerative procedure, it can take up to 2 years for bone to continue to remodel. So we do see continued bone fill over time. So if we look at the left radiographs, you can see we've got this defect here between the 6 and the 7 and how that starts to flatten off. And then by 1 year, that's gone. Let's look at the middle one. We've got between the 4 and the 5, you've got that wide defect there. You see how it's flattened off and how it's gone within a year. And then again, this very wide defect. So again, wide defects tend not to regenerate. The predictability is much poorer, but with lasers, I've developed these protocols that give us these predictable results. So we have this really wide defect here. You can see 6 months later and then 1 year later. So you can see how much bone has reformed. It's so satisfying. Suddenly I felt like as proud as the endodontist because I was able to show before and after radiographs, because otherwise perio was never very sexy. You know, we didn't have great radiographs and pictures to show you, but now with lasers we do. So yeah, very exciting. Just to say, you know, I did tell you I have obviously contributed to the literature with that, and so I've published many papers to support the procedure and describe the exact protocol to regenerate that bone. And then I was delighted to see that then in J-Perio a few years ago, they compared the use of this erbium laser, the water laser, to MIST, which is the minimally invasive surgical technique, and found that it wasn't inferior to that technique whatsoever. So it got just as good results, but it was faster. So that's going to save you surgery time, save costs, and also superior patient-related outcomes. So less pain, less bleeding, less swelling, less need for an ice pack, less anxiety, and more patient satisfaction. So why wouldn't you? That's all I can say. Let's start looking at a few cosmetic things here as well. This is actually a patient who didn't really have pockets, but she had severe lichen planus, which looked very unsightly. She had quite a gummy smile as well. So when she smiled, you could see all of this massive red inflammation, which was obviously really quite painful and would bleed a lot as well. So again, I use the erbium laser there to remove the underlying tissue, and I've used the diode laser to help with the anti-inflammatory effect, and you can see the beautiful results just within a couple of weeks. So very satisfying. Let's talk about implants a little bit. We'll look at some soft tissue around implants, and we'll look at some periimplantitis cases as well. So periimplantitis, just so we're all on the same page, to diagnose it, we would typically want to see some bleeding and possibly some separation on gentle probing. Sometimes you might not need to probe at all. You'll already notice the tissues are inflamed, and when you press them, if you notice some exudate, then that's kind of your first bit of examination before you pick up a probe. We're expecting to see the probing depths to increase over time, so compared to previous examinations. So a healthy implant might have a 4 or 5 millimeter probing depth that doesn't bleed and never changes. It depends on the depth of placement of the restoration and the abutment. So to bear that in mind. So we want to see increased bone loss and on the radiograph, and increased probing depths as well. That's really how we're going to diagnose periimplantitis, with the primary etiology being bacteria. But here is the thing about periimplantitis. There is no consensus on how to treat it successfully. So we have a ton of papers reviewing different procedures, reviewing alternative treatments, and some of them have looked at lasers, but that's the problem as well, because they use the word lasers as opposed to which lasers, which laser wavelengths. And of course, I did say right at the beginning, each laser does different things and uses different protocols. So we really, really need to bear that in mind. So there is no ideal gold standard, which means we can't compare lasers to an ideal gold standard, but we can show a proof of concept, if you like. And again, I've published papers to support that. So primarily, what are you doing when you're treating a periimplantitis lesion? What are you aiming to do? You're aiming to reduce the bacterial count. You're aiming to remove the granulation tissue, so degranulate the area. Then we want to work on the implant itself. We want to clean it and decontaminate it. And some people will use various chemicals, antibiotic paste, abrasion, but we can also use an erbium, the water laser as well. Then we're going to remove the biofilm as well. That's essential. So again, I know what's going around in your head now because you're remembering, yes, we know the erbium laser can do that. Typically, we might look to see, can we graft the area? Do we need to use membranes? Do we need to use systemic antibiotics? And we very much want to look at the end results. We want to make sure we facilitate oral hygiene as best as possible. Otherwise, the problem's going to come back again. Unfortunately, peri-implantitis treatment never ever looks pretty. Sometimes patients don't actually mind, they just accept it, they take responsibility, and they're so desperate to keep hold of these implants. And we've got to remember, sometimes taking the implant out is not necessarily the answer, because they might not be able to have another one put back in either. So if we can treat it, obviously the earlier the better. Brilliant, but of course aesthetics can be compromised also. So where do lasers come in specifically? Where does this water lase come in? So remember, I told you about this with perio, and this is the application to implants. So it's going to remove our epithelial lining and our granulation tissue, which of course I just told you was a step for treatment. It's going to remove the cement and any calculus that might be there. Fortunately, the days of peri-cementitis are gradually reducing as we go back to screw retained restorations, but that was a big problem. It's going to kill the bacteria, and it's going to remove the biofilms, which is very difficult to do on implant threads. It can also remove the titanium oxide layer and modify that titanium surface to restore biocompatibility. So again, we have histological studies showing true bone to implant contact when that bone regenerates. And we can work on the outer epithelium. So just like with perio regeneration, we're going to delay that creep of the epithelium and stabilize the blood clot as well. And then it can also carry out this biostimulation to get everything to heal faster, to help our bone regenerate and help connective tissue to form. So that was the PBM aspect I was also talking to you about. So how do we get these results? How can we go from this amount of bone loss on an implant on the left to that image on the right, where we have that beautiful bone regeneration? Very similar to what you just saw me showing you around teeth, actually. And I'll show you a video in a sec. But just to back up with a little bit more research, this was just presented just last year at the Academy of Osteointegration, showing that the erbium laser was able to effectively promote fibroblasts and osteoblasts to adhere to the titanium surface without damaging the titanium surface. And again, they're suggesting then that the erbium chromium YSGG, which is the water lase, is superior to other debridement methods when you're trying to treat peri-implantitis. So let me show you what that looks like in this video. So again, I'm using one of these radial firing tips. So it's working on the implant surface on one side, and it's working on the tissue lining on the other. So we're going to loosen up all of the granulation tissue as well. I frequently get asked, how long do we need to spend? What are the settings, etc. Well, again, this is obviously something we cover in a lot more detail in the course to make sure that you understand exactly what you're doing. But it really is really quite simple. The good news as well is that hygienists in this country, at least in the UK, are able to use the water lace for pockets. So imagine getting your hygienist to use a water lace for all those, even those early stages of peri-implantitis. Very satisfying. We do not want to sit on peri-implantitis lesions at all. They can really progress very quickly. So there's lots of water coming out of here as well. Like I said, obviously it's on the video, we're taking that water away. And so we're just understanding the mechanisms of what we're trying to do. And once I've done that, I then get my titanium curette, so I don't scrape the implant surface, and I just again scoop out the bowl. So we're scooping out the granulation tissue. Anyone who's raised flaps to try to treat peri-implantitis will know that this granulation tissue is so unbelievably tough It's really difficult to get out, and you can be there for absolutely ages when you raise a flap around an implant. It's much harder and more challenging than around a tooth. So the idea that we can treat this flaplessly is absolutely fantastic. And then this is a slightly different version because I'm just using a different handpiece of administering PBM, so photobiomodulation, on the implant surface to help with that regeneration. So let me show you a few final results. So this was the patient straight afterwards. That's the healing after a couple of months. So tissues are always very forgiving. We've got a really nice cleansable result there. And you can see some nice bone, oops, go back, some nice bone fill over time. So this was all this tethered bone. And you can see how lovely and smooth it is there where we've had that bone regeneration after a year. And again, 18 months later, she went on to have her crown replaced and continued to show really good stability. I think I looked after her for about 10 years before I left that practice. Here's another lady, I think she was in her 70s actually when we treated her. She had this big defect, I think it was up to 12mm pocketing, if my memory serves me correctly, around this implant replacing the upper 7. So here we are, this is us 9 months later, this is us 20 months later, and this is the result 4 years later. With just one course of treatment, I never had to go in again. I told you it doesn't look pretty, but it's an upper 7, no one can see it. And she's able to clean really well, so we haven't needed to take these threads off either. And you can see really lovely, healthy tissue cuff there as well. So one course of treatment that took about half an hour. So pretty incredible compared to raising a flap and hoping for the best. Here's another case as well. So this guy had 12mm pocketing, and I did tell you about facilitating oral hygiene, right? So if I clean here and I debride, that's brilliant. But if I leave the patient with a situation where they still can't clean and cleanse, it's pointless because the problem is going to come back again because the cause is biofilm to start with. So again, remember my laser is a cutting tool, so I just change the setting and I'm able to carve out these little holes here so that the patient can use interdental brushes. And there we go. That's a lovely, lovely healing with a very cleansable result. And we're down to 4mm probing depths. This was the same patient on the other side. So you can see those really inflamed tissues treated just like you saw in the video, flaplessly. That's all little bits of granulation tissue there. Cut out my holes for them to be able to use interdental brushes. And you can see really nice healing in that posterior region. So we've gone from 10mm to 3mm. And overall, this is his chart. So buccally and pallously, these are our middle numbers. Red meant there was bleeding and blue meant there was separation. So blood and separation everywhere with up to 11mm pocketing. And those are the results after just 2 months. So yeah, trying to raise an implant on a flap around those implants, you'd be there for a couple of hours, even in expert hands. And again, so some nice bone fill for this patient. So we can see this bone loss around these threads, and that's all really lovely and solid after 1 year. This was them on the other side. Again, just showing some really nice, so that bone has filled to that area there, as you can see here on this follow-up radiograph. So yeah, very satisfying. Like I said, I feel like an endodontist again because I can show you these before and after radiographs. Just to reiterate, we do have lots of research around the implants with the use of water lays, and this study in vitro showed that with the correct settings, we know that we're being safe, it actually doesn't damage the implant surface, and here's the real clanger, it's been able to remove 95% of the biofilm, particularly P. gingivalis, which is the most prevalent bacteria associated with peri-implantitis. So that is absolutely massive. I won't go too much into this because I don't want to complicate things, and it's 20 to 8 already, so I don't know how your brains are functioning, but just to highlight to you, these bottom slides here just show you before and after treatment. So you can see different implant surfaces treated before and after, and so you can see the before and after look very similar. So we know we're not really altering or damaging the implant surface. And again, this top graph here is looking at the temperature rise, which we've been able to see as long as we use this 2 watts with irrigation, that's the blue line, We don't have that temperature rise when we're using this laser on this titanium surface. And of course, that's going to be really important because we do not want to heat up our bone. So in other words, it's safe to use. A beautiful development that has occurred with the use of the water laser is the development of something called the side firing tip. So this allows us to rotate this tip so that it fires directly onto the implant surface and cleans the biofilm and anything else that's there all the way through into the depth of the thread. So allows us to do it flaplessly, and of course allows us to treat multiple implants at any one time. So let me show you this lady. She's got periimplantitis. The granulation tissue is just exuding at rest. Really swollen, really inflamed. Cosmetic area, so I've kind of got my heart in my mouth thinking, oh, of course I have to warn the patient that this may expose the implant, but what choice do we have? Not a lot. So she's got, let's see, 11mm pocketing, 9mm pocketing, 11mm pocketing, and then on the buckle we've got 8, we've got 7, yeah, so really, really deep pockets. All of this pus, see all this pus coming out as well. Yeah, I always love it because I just think for me it's like it's really juicy, but that's what makes me a periodontist because I love working on these kind of cases. But here we go. So this is her just when I have finished carrying out her treatment. I'm going to show you some snippets of a video. I'm just conscious of time and I want to get onto some cosmetic things as well. But this is the side firing tip. So I rotate it around so it's just firing directly onto my implant surface there. And again, you can see the water flow. So move on a little bit there. Rotating all the way around. You can see that bit of granulation tissue that's coming out, having loosened up from the bone. So I told you it was very satisfying. So for anyone who has done perio the traditional way, don't worry, you still get that noise with the suction because we do get these chunks of granulation tissue that come out, but so minimally invasive. And then this is her result later. So 2 weeks later, you can see really nice tissue healing, minimal exposure. There was always going to be a bit. And then again, you can see before we've had how much bone we've got missing, and then after, particularly look at this one here, you can see that bone is right back to normal. So yeah, really satisfying compared to how it looked beforehand in a minimally invasive way. And of course, no pocket. So we're down to 2mm, 2mm, 1mm. It's pretty good, huh? From 11mm with separation. Again, as I've said to you, we have some lovely research showing the efficacy of the water laser on implant surfaces and how this particular study has then looked at re-osteointegration. So to show that when we use it with the water laser, we do restore biocompatibility, and they've shown true bone to implant contact as well. So very satisfying. And volume down there. I did allude when I was showing you that PRF case to the fact that when we're treating periimplantitis, one of the reasons why it doesn't work or doesn't remain stable is if we have a mobile margin, which it was the case here. So this chappie had periimplantitis, but you can see he's also got some frenal pull on that area as well. So I know if I treat that area, I don't have much keratinized tissue here, and the margin is mobile, which means I'm much less likely for my periimplantitis treatment to be effective. So you have the tool and the machine there to carry out a beautiful frenectomy using laser, which I did before I went in to do the periimplantitis treatment. So it gives us options. We're able to do so much more than we could before. Here's another case, actually, just moving on to some cosmetic things. And again, this chappie, we treated his periimplantitis again. He'd had widespread 12mm up to 12mm pocketing around this implant. So now I've started to do a graft. So I'm use my my erbium laser on my implant surface. Remember, restores biocompatibility, attracts fibroblasts to it, and then I'm going to use my diode as well for post-op pain, but also improving healing and blood supply. So I've taken some tissue from the palate, and then this is me using PBM, so using my diode laser, which I use at every stage that I see the patient for a review. And in doing that, have had just fantastic results. This is just literally 1 week later. That's a couple of weeks later, and then that's 3 months later. So we have this much, much thicker tissue, and he just changed that crown at the end and went on to save that implant. So very satisfying. Here's another cosmetic case, again, trying to use some lasers. Obviously, we can see here the implant's been placed high up and really quite buccal. So they followed where the bone is, but then it was like, Rena, can you help me somehow? So I wanted to bulk out this tissue, because if you have your implant placed and you don't have bulky tissue at that point, then it's going to recede and you're going to have all this metallic exposure down the line. So a little bit of prep work beforehand. So you can see that was the bulk of the tissue there. So again, I've used lasers to raise these minimally invasive flaps and loosen up the flap so that I can apically reposition it. And I've used my erbium laser on the metal surface as well, so to decontaminate it, so that whatever I'm going to place on there, in this case you'll see a membrane, is going to really help to pad it out. So that's exactly what we've done. So I think it was it I think it was Alloderm in those days. It's quite an old case. We've got a lot more options nowadays. And again, you can see we've sutured that area up, and PBM, so we've improved the blood supply and reduced the post-operative pain. So you can see 6 days later, really lovely tissue healing, much bulkier tissue, which is going to give this patient a much more stable result down the line, where they're much less likely to get further recession. So it's obviously, I can't do anything about how high it is, but I can at least make sure that that metal surface is not going to be exposed in time. So it's just an idea of how we can do some prep work around implants as well. So quick whistle stop tour on some recession, frenectomies, and some crown lengthening as well. So I can't go too much into theory, or we really will run out of time. But just to show you a couple of cases here. So this lady, she's actually got some abfraction as well as recession, and a very thin phenotype. So she asked me to try to deal with this and bulk it out. So I have tunneled this particular area. So I use, again, my radial firing tip actually to tunnel under the tissue so that I can place the graft. And then I've taken the graft from the palate and removed the epithelium from it as well. So, but instead of needing to do that with a blade, which is again, I've just used my erbium laser I've taken it out as a free gingival graft, and I'm now using my erbium to remove the surface epithelium. I would do that in situ now as well. And again, on the course, we can tell you everything about size and thickness and how to harvest these areas. But this is my lovely connective tissue that tends to be a lot less fatty. And then I've just used some hemosponge and a suture onto the palate there, although if you have a diode laser you could definitely stop the bleeding that way. And then I've threaded through my big bulky graft onto that area and closed that up with 6/0 sutures. So this is the healing afterwards. I'm just wait for it to remodel. It will flatten and it will reshape and show contour. But actually, and then the other beauty is actually even on that surface, we can then smooth down on the surface to recontour that tissue and get a really nice result. But actually the patient didn't want me to, because she liked the idea it was thick and thought the result would ultimately be much more stable. But this was the problem I had with her. So I showed you what the palate looked like, and she had this bump on the palate and it just wouldn't go, and had clearly formed a sinus and was suppurating as well. And when I first seen her, I tried to dig around thinking there was a bit of a suture there. I thought I'd got it. And then she came back again 2 weeks later and said, oh, actually, now there's this big spot and I just can't get there. So how on earth are you supposed to dig around these soft tissues to try to find what's causing the problem? And this is just exactly the same procedure that we would deal with if you had a patient who had a pyogenic granuloma, for example. But I've been able to go in with the water laser, with my radial firing tip into that hole, and lo and behold, this came flying out. So the cause of the infection is not always a suture. There can be many, many other reasons. I think even remember on my ex-husband, actually, and this isn't the reason he was my ex-husband, by the way, but I think remember it was his birthday, so he decided to come and see me because he wasn't working. He is a dentist. For me to have clean his teeth for him, and then he had this ingrowing hair on his chin actually that kept on getting infected, so I did exactly the same as this, and we got rid of the ingrowing hair and for the spot never to be seen again. So yeah, when you have lasers, you all know you tend to use them off label on loved ones, at least. I mean, my staff used to come in all the time and ask me to remove the pigmentation, age spots and all kinds of things on their face. So I personally choose not to do that on patients, but yeah, so do a lot of off-label stuff on my kids where they've had injured ligaments and injuries and skin infections, and or my dad's skin tags, all kinds of things. It's quite funny, really. You get a bit laser obsessed, but you love it when you have one and it can get you out of trouble like this, and the palate healed up beautifully. Let's look at another recession case. So this lady, she came in saying there's a really bad smell. It was really irritating her, and she couldn't stand the fact that this tooth looked really long, and the dentist had just put this big, white filling to cover over the root surface. Now, beautiful use of the water lays is to actually remove composite restorations without needing to use a handpiece or a drill. So you're not going to cut the tissue, you're not going to damage the tissue, and nor are you actually going to need to remove excess tooth surface. So we can show you the settings to use to actually remove these composite restorations in a minimally invasive way. So again, think of your composite bonding and how much of that is done nowadays. So that's exactly what we've done here, and you can see this little frosting effect. So I've worked on my tooth surface then with my laser to do that root surface modification, which, like I said, we get better adherence of fibroblasts and blood components. So we're going to get better and nicer, more stable grafting results through that. So just a quick video to show you what that ultimately looks like. Again, we're always using lots of water, so we know we're not damaging the root surface. I'm just mindful of time, so I'm just skipping through a few of these, but just so you get a little idea of what that looks like. And then I would blow air on it, and like I said, I have that lovely frosting effect. So I don't need to use pref gel, I don't need to use other pastes, I don't or anything. I just need to use the laser, so it saves me a fortune. I've raised a flap, so we're doing a coronally advanced flap here, and anyone who's tried to do this before will know that it's really hard, because what we're going to do is going to pull this tissue down to this area, and to try to remove the epithelium on these papillae without damaging them can be really, really challenging with a scalpel blade. So the beauty is, again, with the water lace, so precise and shallow penetrating, so we're not worrying about damage because we've got complete and utter control, and we're able to then remove the epithelium on those papillae and then do some release to coronally reposition my flap and suture it up. And so this was the patient before, that's her after. I do live in Essex, if anyone's wondering about the size of the lips. This was most of my patients would come from Essex. And anyway, that is the result afterwards. So really, really lovely. And again, much thicker, bulkier tissue. Again, all using the diode laser for healing afterwards as well. So that's her after, and that's her before. So you can see we've worked on the canines here as well, removing those composite restorations. So very satisfying. Let's look at some other recession cases. So again, using the erbium laser to help me tunnel this area. So we wanted to deal with recession on both of these lower teeth. So I've used my radial firing tip to tunnel my way through, harvested my graft, and you can see that etching there, that frosting on the root surface, because I've then done that root surface modification before I graft. And let's have a look. So I've got my connective tissue graft, which in the old days, again, we just take with a single incision on the palate, and then we've placed it there, sutured it in place, all sutured in, and then of course PBM. So that's definitely how we're getting these beautiful, beautiful results post grafting with the use of the diode laser. So that's her 2 weeks later, 4 weeks later, and really nice remodeling and keratinized tissue 3 months later. So that's a before and after for you. So yeah, getting really lovely results by continuing to use the diode laser afterwards. Here's another one, it's very similar. So again, we've used the erbium for that tissue modification, frenectomy, and then the diode post-healing. You can see really lovely, thick, bulky tissues. And again, this one, so we would have done a frenectomy, root surface modification, connective tissue graft, and diode as well. And really nice healing. See how thick those tissues are. So how do we use the erbium for root coverage? So I've mentioned removal of composite restorations, of course, removal of caries, removal of the smear layer, modifying the root surface, deepithelializing the papillae, vestibular deepening, I'll show you a case of that in a minute, and frenectomies. Desensitization, again, is something else we can do both with the erbium and the diode, so we can desensitize teeth. Harvesting grafts, stopping them bleeding, laser band-aid, all kinds of things. So I'm really nearly out of time, so I'm going to whiz through these last couple of cases. You can get patients who have these hemangiomas, so these big purple swellings on volume now. Oh, okay, my video's decided not to play. It did this last time actually. I thought it was working. Okay, well I apologize. When you come to the course, I'll show you the video. But again, I've just literally used a diode laser here with non-contact mode, just shining it over this area. And then what we see is the area becomes a slightly grey. Beautiful, we've got the video able to play. So you can see I'm just using the diode in non-contact mode. I do numb the patient up because it does feel quite hot. And we carry on until the area it kind of grays over and frosts over a little bit. And then we warn the patient it's going to scab. So that's exactly what happened. It scabs over, the scab disappears, and that is our patient afterwards, and that is before. So I'm sure you definitely agree that's a cosmetic, beautiful cosmetic case in something that is non-contact. Frenectomies, I mentioned them. I've shown you a little bit about what we do. So just a few before and afterwards. Fantastic around implants or crown lengthening cases. The advantages, they don't grow back. Patients can eat and drink straight away, and patients can brush their teeth straight away as well. So just by releasing this tension. And so sometimes we don't even need to graft for that reason. So here's another one. Before and afters, and always I do it with the erbium and then always the healing with the diode laser, so the patient has no pain afterwards. This is what a vestibular deepening looks like. So again, just the erbium laser from the margin of the mucogingival junction, and just working my way across, separating the fibers down to the periosteum. So that's fantastic, again, pre-implant work, right? And thin phenotypes and generalized recession cases to be able to do that. You'll get a lovely zone of keratinized tissue around your implants if you use this procedure as well. Again, it's something we teach you on the course. There's a simple before and after to give you an idea of exactly like that video. Had a really shallow vestibule here. So I've just done this vestibular deepening. You can see how deep the vestibule is afterwards. This happens to be around teeth, but like I said, really useful around implants as well. Last couple. This is a young chap. He's just 17 years old, and he was so conscious of his smile, his gummy smile. And when I kind of narrowed it down, it's pretty difficult, as I'm sure you'll agree, to get much out of a 17-year-old for them to really tell you what they're bothered by. But when I got his mum to leave the room, I narrowed it down to the fact actually he just didn't like the bulkiness of the tissues and the gums, and that was what was making him even more self-conscious. So gingivoplasty here, using the erbium. I told you we could be really precise, right? So we've lengthened the teeth a little bit and we've debulked it all on the surface, creating the bevel as well. And he was absolutely delighted. It was a pleasure when he came back to see the real smile on his face. So it's an amazing application. Here's a crown lengthening case. So we are able to remove bone flaplessly using the erbium laser. So this guy, he wanted us to match up the tooth lengths on both sides. So that's exactly what I've done here. I've done some crown lengthening with a gingivectomy. I've then done the bone removal flaplessly, all with the laser, and I've carved out the pontic site here as well. So all in one visit. That's the patient 1 week after treatment. And you can see that pontic site has healed really, really well. So minimal pain. If you did that with a handpiece, it'd be really painful. An alternative for bone removal means you'd need to raise a flap. So this is him post-treatment. And he was really, really happy, and that was the before. So you can see we've done that flapless crown lengthening there. So again, really nice potential for some lovely, lovely cosmetic work there. I always say now, what he really needs is just a bit of Botox though, on that top left-hand side. Let me just show you very quickly what that looks like. My funny music playing. So this lady, she had a gummy smile. So this is doing the gingivectomy. This is done by a brilliant periodontist, Gaston King, who actually taught me when I was a postgrad student. And then I got the chance to teach him lasers. So one of the things I do sometimes is I'll come out to your clinic and sit with you chairside for a whole day, and we'll just go through a ton of procedures and get you to do them. So that's exactly what he did. So we got to try pretty much everything that day. So you can see he does the gingivectomy, and then he goes underneath the tissues to do the flapless bone removal. So again, that's something we will teach you exactly how to do on the course, and how to make sure that that bone is really lovely and smooth. So that's a quick example of some crown lengthening, and then the final contour to produce that lovely bevel. This same patient, like I said, she had a very, very gummy smile. So again, I'm just going to show you a tiny bit of it because we don't have much time. Oops. Let's turn it out down. Yeah, so the next thing he wanted to do was get rid of the gummy smile. So we're doing something called a reverse vestibuloplasty here. So again, all done with laser, where we basically take a strip of tissue and then we suture the lip at a much lower level, so when they smile, they can't smile anywhere near with as much gumminess, I should say. Lots of indications for when you, and we wouldn't do this, how much tissue you remove, if you need added tools, if you need Botox, etc. Again, it's something we teach you that on the course. But we know now with reverse vestibuloplasty, really, you want to keep it as superficial as possible and only really try to remove the epithelium. So again, that's so hard to do, not to go deep with the scalpel blade. But again, with the erbium laser, you can see here just the ability to take away just a really thin layer of the epithelium, which is what he's done there. And then eventually he sutured it all up with these interrupted sutures, and then we're using that PBM inside and then outside all around the cheek area, moving it down to reduce the post-operative swelling as well. So really satisfying. And he got a really nice result there. This is an example of another patient who I've treated that way, so you can see the results you can get with that procedure. Fantastic, and the use of lasers make it so much fun. Depigmentation is also something you can do cosmetically. So in this case, the patient just had pigment on his papillae and it was really bothering him. So again, we're just able to remove that so precisely with the waterlays down to the melanocytes, and you can see the result afterwards. So again, that can work really nicely cosmetically. People ask me about lip depigmentation and tongue depigmentation as well. They're all very similar procedures.